So again, good afternoon to everyone. We will continue our discussion for this afternoon related to the pharmacokinetics. We have started the stages of movement in the pharmacokinetics with absorption, and one of the basic description and definition of absorption is just remember the AAS. And what does AAS means? A stands for administration site. Another A is across tissues, and the S is reaching to systemic circulation. Now, we have already started with the video presentation on the pharmacokinetics, specifically on the distribution. So probably we'll proceed to the next slide. When we talk about the distribution, this is the time that the drug already reaches the systemic circulation, specifically the plasma. So in the absorption, it ended up with the systemic circulation, and after that the drug reaches the systemic circulation, this is not the time that it will be going through into tissues. So that's why if we will try to differentiate absorption between absorption and distribution, for absorption it's across tissues, but if we're talking about distribution, it goes through into, okay, into the tissues itself. Because if you have remembered the video, the audiovisual presentation that we have that I have presented last time, that when the drug, for example, had been administered by intravenous and direct to the plasma, it will distribute to the various compartments. It has mentioned it could be distributed in the extracellular compartment. It will be distributed into the intracellular compartment. It could be distributed to the fatty tissues. It could be distributed to other tissues. So the other tissues and compartments that we mentioned are all about fluids that could be present in some of the organs. Example that we mentioned are for the fetus, we have the amniotic fluid, we have the joints and the bones rather, we have the synovial fluid, we have for the heart, for the peritoneum, we have peritoneal fluid, for the brain, we have the cerebrospinal fluids. These fluids are necessary as part of the distribution because we all know that the waste products and the nutrients and the waste products are transported by the plasma, including the drug's chemical property or components. So when we talk about distribution, as what I have mentioned from the plasma, it goes to the tissues. And even during the discussion of the absorption, we have identified already what are the factors that may affect the degree and the rate of absorption during the time. We mentioned about the age, we mentioned about the health condition, we mentioned about if it is lipid soluble or water soluble. We mentioned also that it may affect if there will be interaction with food or drinks. So those may affect absorption. But when it comes to distribution, since this is the time that primarily it will be distributed already to the various indicated organ. So there are several physiologic factors that may significantly affect distribution. So plus in the brain, we have the what we call BBB. The BBB stands for blood-brain barrier. So the blood-brain barrier, from the term itself, barrier. What does it mean by barrier? Anyone? If we say barrier.
Harang po, sir.
Yes. So it's similar to a protection. Okay, it's the protection component of the brain. So that's why anything that comes to or that enters the brain itself will be protected. Example, do those drugs that are carried by the plasma may directly affect the brain? The answer is no, because we have the blood-brain barrier. For example, sir, if we have the virus that enters the brain, will it cause directly inflammation to the brain tissues? Not yet, because we still have the blood-brain barrier. If, for example, if there are other components of the drug, such as if you are aware of CT scan, are you familiar with CT scan?
Yes po, di.
Yeah, most of the CT scan, if we say cranial, okay, if we say cranial CT scan, the computed tomography that is considered as diagnostic examination. If we have cranial, obviously it's the brain. Okay. So if it is by X-ray, it's only the structure itself that may significantly identify. But with the CT scan, it may identify other parts, lobes, if there are problem with clots, if there are problem with dead tissue or tissue death. So that is more a deeper view when it comes to what we call CT scan. But if we try to consider to identify the status of the blood vessels, that's MRI, the magnetic resonance imaging, MRI. So this may identify a deeper structure, anatomical structure of the brain. Now, if for example the client will be subject for CT scan, the patient will basically receive a dye, DYE, a dye. It will be administered intravenously, and this dye, DYE, so di ba pag if we say dye, literally we are aware color. Okay, so the dye will be carried by the plasma until the circulation will be entering the brain. So that dye that goes with the plasma and until it will circulate to the brain will identify the flow of blood, if there are obstruction, if there are blood vessels that are damaged, if there are blood vessels that are what do you call this, other than damage, if there are blood vessels that are obviously inflamed. So because the blood will not facilitate free flowing to the brain. So in this scenario, the dye itself is the one that will guide in the monitor if we have a healthy blood vessel, tissues in the brain. Now, that dye will definitely transported by the plasma. It is not indicated to stay in the brain because it is just for purposes of seeing and monitoring the status of the brain. So the dye must be excreted and be eliminated by the kidney. So that's why students, when you are about to assist a client with subject for CT scan, so yung cranial CT scan with contrast, if it is with contrast, ibig sabihin it will administer a dye. If it is only a cranial CT scan plain, it will not administer a dye in the intravenous site. So if it is with contrast, it is with the dye. So it will facilitate that dye that is carried by the plasma to check if there are obstruction in the brain or problems with the blood vessels in the brain, or if there are ruptured blood vessels in the brain. So on that level, that dye itself, as what I have mentioned, could have a direct damage to the brain tissues because that dye is a foreign a foreign substance yun, that is not merely and identified in the circulation. So that's why the blood-brain barrier is the one that is basically important as a protection layer for the brain so that it will not direct any chances of damage to tissues, and this will protect initially from any toxic effect. If the blood-brain barrier is affected, example, these are endothelial tissues. If the blood-brain barrier, for example, what are those situations that it may cause the damage in the blood-brain barrier? For example, direct head injury. The direct head injury, the force itself may have a direct damage to blood-brain barrier. So probably pwedeng mag-cause yan ng profuse bleeding. Okay? So another that could lead to damage to the blood-brain barrier is infection. If there are bacteria or virus that is carried by the plasma and eventually cause inflammation in the brain, that may cause inflammatory process or condition in the blood-brain barrier, so it may not serve its purpose of protection. So actually, there are situations like na if the blood-brain barrier will be damaged, it may cause a direct effect to the brain. So one of the considerations, if the blood-brain barrier is affected and the toxic effect is brought about by any foreign substance such as drugs that had been administered and goes with the perfusion and circulation to the brain, the patient will definitely manifest either it will change his consciousness from alert and somehow may become lethargic or drowsy. Second is if the patient experiences seizure. So those are situations wherein blood brain barrier are damaged. So the blood brain barrier, as what I have mentioned, is the protection layer, so that the drug itself will be distributed throughout the body. So next is cardiac output. Okay. When we talk about cardiac output, obviously, the normal cardiac output, if we go back to anatomy and physiology, how many ml or probably liters is the normal cardiac output? What is the normal volume of cardiac output? Anyone? In ml or in liters? Per minute. This is per minute, ha? Because every time that the heart pumps, it brings out a cardiac output. Anyone?
5 to 6 po.
Huh?
5 to 6 liters.
Okay. That's good. That's correct. It's 5 liters or 5,000 ml. So, probably if you will go back to anatomy and physiology, what what will make the heart what will make the heart have what will make the situation of the heart eject less volume of blood? What are those situations that may affect the cardiac output or less or low cardiac output? For example, 'di ba the largest blood vessel, which is the aorta is the one at the end of the left side of the heart, may eject circulating blood to the systemic circulation, the oxygenated blood. Um, if you will check chest X-ray, it is indicated in the chest X-ray atheromatous aorta. Try to observe that, ha, if you will check results of chest X-ray. If there is atheromatous aorta, class, always take into consideration the term atheroma as fatty plaques, cholesterol. These are situations that are associated. So if we say atheromatous plaque, it means that there are lots of plaques such as fatty plaques that are present in the aorta. Do you think that fatty plaques that are dislodged in the aorta may cause obstruction? Do you think?
Yes po.
So do you think if it will cause obstruction to the aorta, it may limit the cardiac output?
Yes po.
Yes. So that's why for those who may have atheromatous aorta and you've seen in the chest X-ray, oh ma, you have atheromatous aorta, it means that there are fatty plaques in your aorta that may limit cardiac output. Wow. So that brings you confidence in explaining what atheromas is. So pag sinabing atheromas, these are fatty plaques. So do you know that if we go back to the anatomy and physiology, how many percent of the cardiac output goes to the brain? It has the highest percentage that goes to the brain. Any guess? How many percentage goes to the brain? So hearing silence, we have 40%. 40% of the
20 to
card.
25%.
Okay, so it's still within the range. Very good. It's actually 40%. So it's still with the range of 20 to 55. So the 40% goes to the brain, another the 20% goes to the kidney, and the other percentage that are remaining, which are the 40%, goes to the different parts of the body. But the highest percentage of the cardiac output goes to the brain. That's why if there are limitations in the limit there are limitations in the cardiac output, the most affected part of the body is the brain, right? So that's why usually those who may have less cardiac output are those who may have hypertension. From the term itself, hypertension, hyper, increase, tension. So ibig sabihin, if there's increased tension, what causes the tension? The cause of the tension is merely the volume of the blood is increasing and are not facilitating to 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 circulate freely to the various systemic circulating pathways including the brain. So that's why if the brain will be deprived from supposedly 40%, the person is high risk of stroke or cerebrovascular accident. Just the same as for the effect of the drug, if the patient is experiencing hypertension, it is expected that cardiac output is decreased and mainly may affect distribution of the drug since it is carried via plasma. Another is another situation that may decrease cardiac output is mainly if the left side of the heart before going to the aorta, or di ba we have the aortic valve and we have the aorta, is the left ventricle, di ba? The ventricles are the ones responsible for contraction so that to eject the blood. If for example in the left ventricle, the muscle tissues, there are identified muscle tissue death. So if there are death in the muscle tissues, do you think it will still have effective contraction? Yes or no? If there are muscle, no. So do you think it will affect the ejection of the blood?
Yes po.
So do you think since there are muscle tissue death on the left ventricle, it's not that forceful as we expected? Is there a possibility that not all the volume of the blood in the left ventricle will be ejected? There are more volume that will remain and less volume that will be considered as cardiac output. Yes or no?
Yes po.
Yes. So is there any are there any instance that in the left ventricle that it will increase the volume of the blood as expected? Because again, it will proceed to diastole, then it will refill again. So do you think because the ventricles are not contracting due to tissue death, it will remain more volume in the left ventricle? Yes or no? Yes or no? So I repeat it again. If for example, in the left ventricle, there are tissue death. And the tissue death that we are mentioning are muscle tissues. And muscles are capable of contracting. If there are tissue death, we have concluded that it will affect contraction. If it will affect contraction, it will affect ejection of blood. And thus, if there will be less contraction of the muscle during the refilling of the blood, do you think remain it will remain or retain more blood rather than ejecting blood? Remain or more on ejecting blood? Which is
Remain
more?
po.
Okay, it will remain. So if it will remain, do you think it will cause pressure on that ventricle?
Yes po.
Yes. Eventually, if it will increase the volume of blood in that ventricle, do you think the heart will increase its size because of that increasing volume of blood?
Yes po.
And that's the time that the heart becomes cardiomegaly. So that is the heart enlargement. Once the heart will have a heart enlargement, that is an indication that the heart is increasing its volume but not ejecting it. So that's why if there will be decreased cardiac output, do you think it will affect distribution of drug via plasma? Yes or no? It will affect or not? Again, I'll repeat. I'll repeat. If ever there is an enlargement of the heart and there is increased volume of the heart, volume of the blood in the heart, do you think it will affect the ejection of blood? Yes or no?
Yes po.
Yes. So that affects cardiac output and it may affect also distribution of drugs. Okay. So class, please let me know if there are some portions of our discussions that are not clear before we proceed to the next slide. Another, how about consideration with anemia? A person who may have anemia is expected to have high volume of blood or less volume of blood?
Less po.
Less
Okay,
volume.
less volume, correct. Do we expect for a person with anemia high level of oxygen or low level of oxygen?
Low po.
Very good. So ibig sabihin, if we say anemia, low level of oxygen, low volume of blood. So do you think with the low volume of blood, it may affect also distribution of drug components? Yes or no?
Yes po.
Yes po.
Yes, that's why for those who
Po.
may have anemia, class, the doctor will always take into priority to correct first the problem with anemia prior to giving or prior to proceeding to pharmacologic management, because it may eventually not achieve its desired effect because of the situation of anemia. So we need to correct first the status and the situation of anemia. Next, body composition. On the body composition, amount of adipose tissues. Okay. For example, obese. Okay. For obese individuals, do we have high volume of adipose tissues or low volume of adipose tissues? For obese, high volume of adipose or less volume of adipose tissues?
High volume
Hi
po.
po.
Yes. If we have high volume of adipose tissues, do you know that this may cause less metabolic response? If high adipose tissues, less metabolic response, the cells will also have less response in distribution of drugs. That's why if you will notice, those who are obese are the ones who are experiencing fatigability easy fatigability compared to a person who has the what you call this, the ideal body weight. Simply because the person's adipose tissues are the ones that basically affects the metabolic response. And once metabolic response are affected, the cells response when it comes to drug distribution are also affected. So another, we have letter D, blood supply to target tissue. So this is what I have mentioned. If we have anemia, okay, so we have decrease in diagnostic examination. Usually we expect for anemia less decrease RBC, decrease hemoglobin, and decrease hematocrit. So the hemoglobin itself is the one that identifies the level of oxygen, and the hematocrit is the one that identifies the viscosity of the blood. So that's why if the person may have anemia, low viscosity of the blood, low oxygen. How about what is the term that is identified with increase in RBC? Anyone? If we have anemia for the low level of RBC, how about for high level of RBC? Do you know the term? So I'm not hearing anything, so I'll just reveal it. The term for high level of RBC is polycythemia. Okay, polycythemia. P-O-L-Y. So I'll just type it. So polycythemia. Polycythemia. Okay, polycythemia. So this is increased RBC. Increased RBC level. In the increased RBC level, this is now the problem. If we have a problem with the low volume of blood in anemia, the problem naman with increased RBC is, 'di ba, low volume. Kung ang polycythemia is high volume, do you think the viscosity is higher compared to anemia? Can you imagine that? The viscosity, or a colloquial called as malapot. So do you think if highly viscous yung blood, slow din yung flow niya sa blood vessel? Yes or no?
Yes.
Yes. So if there is increase in the viscosity of blood, there's also somehow din ba a delay in the transport of the drug chemical distribution of chemical properties of the drug via plasma? The answer is
Yes.
yes. So that's why a person who may have anemia, a person who may have polycythemia may significantly affect distribution of the distribution of the drug via plasma. Next E, degree of vessel constriction and dilation. Okay. What are those situations that may cause the vessel constriction? Class, for those whom you've known who are drinking too much alcohol, too much, I'm telling you, too much alcohol. Do you know that the alcohol may cause vasoconstriction if it is too much in blood? We all know the same as for the drug, the liver is the one that detoxifies. However, if there will be an increase in the level of alcohol in the blood, there could be a possibility also that may delay the response of the liver, and moreover may increase the level of alcohol in the blood. So what happens if there is an increase in the alcohol level in the blood? This may cause vasoconstriction. That's why if you have noticed, some of those who may have high level of alcohol, it changed, literally it changed their consciousness. From alert, they become drowsy, and somehow they will have the level of sleep. Because that situation is that of the brain is already deprived from oxygen. And the body response itself is for the person to reserve oxygen. So that's why for those who may have continuous drinking of alcohol in spite of drowsiness, the level of consciousness is also decreasing in a way. So that's why what is the reason why decreasing the level of consciousness? It's because the too much alcohol in the blood may cause vasoconstriction. Somehow, even smoking itself, the smoking, what's in the smoke that is very known that may cause harm to the body?
Nicotine po.
Nicotine. The nicotine itself, even we have the alveoli, we have the alveolar sac, and we have the alveolar fluids that may prevent its diffusion or transport to the various pulmonary blood vessels. But the nicotine, because it's very harmful, it already causes constriction of blood vessel. So if there is constriction of the blood vessel, it may also delay gas exchange. So somehow there are some situations, or there are individuals whom you observe that both drinking and smoking at the same time. Can you imagine that situation, that it will cause multiple constriction of the blood vessels? So that's why in this situation, when the person is smoking, when the person is on a high level of alcohol, it is not advisable to take and administer any medications at all, because it may just only counteract, it may not proceed to its distribution. Next, degree to which the drug binds to plasma proteins such as the albumin. Actually, class, the albumin, the plasma protein, is the one that binds, okay, that binds these drugs so that it will be distributed. But somehow, if there will be an increase in the albumin is the one that counteracts the binding of the protein with these chemical components. So how can you identify if the person may already have increase in the albumin level? Via urinalysis. Via urinalysis, albumin could be identified. And once it could be identified, usually those who may have findings of protein and albumin in urinalysis, they are known to have increase in the blood sugar or somehow risk for diabetes. So this may cause the possibility of affecting distribution of the drugs. Any questions from the several physiologic factors affecting distribution? Any question from the floor? I'm not hearing anything.
None po.
So far po.
So far, none. Okay, none that you have learned. None is clear. Okay, so at least it's clear. So let us now proceed with the next slide. We will now proceed of what metabolism is.
Hi, welcome to the fourth handwritten tutorial on pharmacokinetics. In this tutorial, I'm going to talk about drug metabolism. Drug metabolism often takes place in the liver, but metabolism can take place elsewhere, such as in the lungs or the gut. The fact that most drugs get metabolized by the liver is very important for pharmacokinetics, because drugs given orally may be metabolized by the liver before they reach the systemic circulation.
Okay, di ba I keep on emphasizing this, that any oral administration route will always consider detoxification of the liver, such as the first pass effect. But for those that had been administered intravenously, the process of metabolism and excretion may possibly happen on other routes. If it is taken inhalation, since it did not pass through the first pass effect of the liver, it will be through the exhalation. process itself. For those that are other means of excretion, it could be via intestinal or it could be via the integumentary system or the skin.
This phenomenon is known as first-pass metabolism. Sometimes first-pass metabolism is so dramatic that it necessitates giving a drug intravenously, as giving it orally would lead to significantly less active drug in the systemic circulation. Morphine is an example of this, which is why it is so often given intravenously rather than orally.
Okay. The drug that was mentioned by the presenter is morphine. Okay, morphine is a drug. Okay, is a drug that is usually given as preoperative medication prior to the induction of anesthesia. It was mentioned that morphine is advisable to be given more on intravenous and not on the oral route. So we will discover why. Let us continue.
However, in this tutorial, I'm going to talk more about the biochemistry of drug metabolism. In particular, the actions of cytochrome P450 enzymes, which are often abbreviated CYP. These cytochrome P450 enzymes are abundant in the liver and different types metabolize different drugs. For example, CYP1A2 metabolizes caffeine, whereas CYP2E1 metabolizes alcohol.
So the one that is usually secreted by the liver, so it has particular cytochrome that detoxifies level or increased level of substance in the body. Diba it has mentioned a different cytochrome intended for alcohol, a different cytochrome intended for caffeine, and a different cytochrome that is intended to metabolize the drug. And the cytochrome that has been identified to be secreted on the metabolism and first pass effect metabolism of the drugs is cytochrome 450.
Cytochrome P450 enzymes metabolize drugs through a variety of processes. These include oxidation, hydrolysis, and hydroxylation. So let's have a look at how this works. And I'll try and keep the organic chemistry to a minimum. Here is a drug, and this drug has a hydrogen attached to it. This hydrogen is going to be the target of our cytochrome P450 enzyme. Through the process of hydroxylation, the cytochrome P450 enzyme has turned the hydrogen into a hydroxyl group. But metabolism doesn't stop there.
Okay, just to give you a simple approach on this, I know and for a fact that oxidation, hydrolysis, and hydroxylation had been introduced to all of you in biochemistry. So that's why biochemistry is very relevant here in pharmacology when it comes to the process of oxidation. If you have noticed in this situation, the H component of the drug is the one that is being identified to maximize the hydroxylation. So what do you mean by hydroxylation? The hydrogen itself, the hydrogen component of the drug is the one that specifically focus on the cytochrome 450 so that to facilitate the detoxification. And that detoxification follows the three process. The three process are the following: the oxidation, the hydrolysis, and the hydroxylation. In the oxidation, the one that is focused for the cytochrome P450 is the hydrogen. And when it comes to the hydroxylation is to process the OH. The OH that we are talking about by the cytochrome P450 is to facilitate and separate this component to prevent toxic effect of the drug.
The presence of this new hydroxyl group creates a target for much larger molecules to be attached. There are many enzymes which can act upon this newly formed group. Here we will look at a common one, UDP glucuronyl transferase. Through the action of UDP glucuronyl transferase, a large
So probably we will not focus more on the technical components on discussion of the chemicals pertaining to the metabolism, but simply we will just proceed on the purpose of how it will be excreted. So from this point, we have the phase 1 and the phase 2. The phase 1 that we are considering here is undergoing this process of oxidation, hydrolysis, and hydroxylation. So again, always remember the cytochrome P450. The cytochrome P450 is the one that specifically facilitates detoxification of the drug by the liver. And through this process, the phase 1 goes with oxidation and focus on the synthesis of hydrogen. Once this will be separated, it goes to the phase 2, which is the hydroxylation, and that focuses on the synthesis of the hydroxide. Now, on this process, this will facilitate the other components of the drug so that these other excess components of the drug will coordinate to the kidneys. And the kidneys are the excretory port of some of the chemical properties which is not needed by the body. One example that are posted here in the video is related to aspirin. So I've discussed, di ba, heparin, aspirin, warfarin, drugs. What are the common suffixes with that? The common suffixes is ending in "rin", di ba? So these are anticoagulant. Point, anticoagulant. These are the drugs that will prevent clotting. And those clots are the ones that may cause obstruction of blood vessel. To continue with this excretion of the drug once it is processed accordingly.
Because of this, we call aspirin a prodrug.
Okay, so this aspirin now will be processed by the kidney with other components that are needed by the body and will be eliminated accordingly. So we will not anymore focus on the technical aspect of the metabolism, but if you wish, you can still watch this and posted in our MCU BLE. Let us now proceed to the other slide. So now, if we have talked about AAS for absorption, administration site, across tissues, systemic circulation. If we've talked about distribution, we are talking about SI, systemic circulation into tissues. When we talk about the metabolism, this is usually processed and occurs in liver, plasma, kidneys, or intestinal membranes. So that's why the liver, the plasma, the kidneys, and intestinal membranes usually are the ports or wherein the other products of metabolism are excreted through this organ. Specifically, if with the liver, it's in coordination with the kidney. If with the liver, it's also in coordination with the intestinal membranes. And for the others, plasma, it will be excreted to other means within the body. Now, that's why most of the drug, if you will observe, may cause discoloration of urine. There are some drugs that may cause discoloration of stool. And there are some drugs that may cause observation on odors, because these are the other means that the drugs already are reaching the metabolism, and with this excretion, the product of excretion goes with these various organs. So it will be affected by genetics. What does it mean by genetics? Class, there are some diseases that are inherited. And those that are inherited, example, there are blood disorders that are inherited. If you will encounter those thalassemia, these are inherited. Thalassemia are problems when it comes to the structure of the red blood cell. Usually, class, if you will encounter usually this appears this usually inborn. That's why it's mentioned as genetic. and since it has a problem with the structure of the blood itself, and the person could be high risk for bleeding. So that's why if you have known persons with thalassemia, they are usually subject for blood transfusion. So pag nag-bleed talaga, if those persons who may have thalassemia will bleed, they are directly subject for blood transfusion. And usually, if those persons may have genetically inherited diseases, we have mentioned a while ago that it may affect when it comes to volume of blood. It's either high RBC or low RBC level. Next, metabolism may also affect patient's age and condition. Since we have mentioned the various organs of the liver, the plasma, the kidney, and the intestines, any disorders affecting these organs may significantly affect metabolic response of the drug. Moreover, we have talked about metabolic response on age. I even enumerated to all of you which of the following population groups has the slowest metabolic response: children, adult, or elderly? Your answer, I think, is majority of you answered what?
Elderly.
The elderly. Correct.
Elder po.
Elder. Okay, the elderly. The elderly. So the elderly has the slowest metabolic response because remember class, even at your age, why some situations like at your during your age, when you eat too much, why is it that you are not risks for increasing abdominal size or circumference? Because your metabolic response are active. But once a person reaches 26 years old and above, and somehow the person is engaged into low physical activities, that's the time that you have noticed that their tummies and abdominal circumference are increasing. Because that's the point that at reaching 26 years old, the metabolic response or metabolism is decreased. Moreover, as it increased the age, the slower the metabolic response. Moreover, for elders, they may have the slowest metabolic response simply because of situations of the cells that may not reserve enough nutrients compared to adults and children. So this may affect the metabolism of the drug. So it could be affected also by the drug itself. So we have mentioned, di ba, lipid soluble and water soluble drugs. So if you can still remember our discussion, which of the two mainly considers a fast pace of breakdown of the chemical components of the drug? Is it the lipid soluble drug or the water soluble drug?
Water soluble po.
Correct. The water soluble drug may interact primarily with hydrochloric acid compared with lipid soluble drug. So now, we have mentioned about first pass effect. Okay, the first pass effect that we mentioned is only metabolized by the liver. Pass through the liver and metabolize before entering the systemic circulation. Usually, for higher dose of drugs that have been administered to the body, the liver is the one that will function to significantly metabolize. Identified usually are oral administration or route of administration. So it will identify the first pass effect or the what we call first pass metabolism. Now, after the metabolism, let us now proceed with the excretion or elimination.
Hi, this tutorial is the fifth in the Pharmacokinetics series. In this video, we'll be discussing excretion of drugs. Excretion is defined as the irreversible removal of drugs from the body. There are two main ways in which the body excretes drugs. One is via the hepatobiliary system. This is when the liver excretes a drug or a drug metabolite into the bile, which in turn gets excreted with the feces. An example of a drug which is primarily excreted by the hepatobiliary system is the antibiotic rifampicin. However,
Okay. Now, it was mentioned here that there could be once the liver will metabolize the drug, there could be two forms of excretion. The two forms of excretion could be via the kidneys in the form of urine, or it could be via the intestine or stool. In the hepatobiliary, usually with the processing and synthesis of the bile, it is expected to be what? To be excreted via the intestine and pass through the stool. So if it is directly through the kidney, so obviously it will be excreted via urine. One of the examples that have been mentioned by the presenter are drugs such as rifampicin and iron-based drugs such as ferrosulfate, which are expected to have discoloration in the stool. That's why always remember that when the patient is taking rifampicin or taking antibiotic of rifampicin is an anti-TB drug, and if the patient is taking the iron-based drug or ferrosulfate probably, so expect that the color of the stool is dark. So that's why it's very important, nurses, to do drug history. Because this may affect or this may significantly have the what we call correct observations, and basically their answers can be validated accordingly if it is an effect of the drug or it is pathologic in nature. Pathologic meaning it is caused by a certain disease.
most drugs are primarily excreted by the kidneys. As such, we will focus on this system in this tutorial. In this system of excretion, a drug gets filtered into the nephron of the kidney. If you want more information on the details of this, check out the nephron function tutorial and other kidney tutorials at handwrittentutorials.com.
Now, we have the nephrons obviously that are present in the kidney. What is the term used for the cells associated with kidneys? These are nephrocytes. And the nephrons are the ones initially accepting the metabolic products coming from the liver.
Once the drug is in the nephron, it flows through the nephron into the collecting ducts and ultimately out of the body in the urine. So we can define some values here. First of all, there is a certain concentration of the drug in the plasma.
Okay, so as what we have mentioned, the drug, the properties of the drugs, the metabolic products of the drug from the liver will be initially will initially enter via the nephrons and will be transported up to the collecting tubules of the kidneys.
We'll denote this CP. Secondly, there will be a certain concentration of drug in the urine. We'll denote this CU. Finally, there will be a certain rate at which urine is being produced. We'll denote this rate VU.
So the CP here is a specifically referring to concentration of plasma, okay? Concentration of plasma as it enters the nephron. So the CP. The CU is the one that is referring to when this drug components or chemical components that are considered as metabolic products reaches already these tubules. To continue,
from these values, we can determine the clearance of a drug. The clearance of a drug is given by this formula. Clearance equals the concentration of a drug in the urine times the rate at which the urine is being produced divided by the concentration of drug in the plasma.
Okay, so we will not focus on this formula. However, this is just to give you an overview of what is the representation of the CP and the CU. Class, if you will notice, as a typical example, when you're taking multivitamins, you are aware of the common discoloration of the when you're taking multivitamins, a common discoloration that it created to the urine. But the more that your urine is concentrated, meaning darker from the usual observation that you may have, there are some instances that you need to observe. Because somehow, class, if you have a concentrated urine, there is somehow connection when it comes to the processing of metabolism and hydration as well. That we are talking about fluid balance. That's why if you will notice, the less amount or volume of water that you drink in a day, the more concentrated your urine is. So moreover, if you're taking any drug and at the same time you hydrate yourselves less as with the expected volume, expect a higher concentration of the urine. And this could be harmful, class. The hydration, the discoloration of the urine, which is darker from the usual, means that there is already a concern pertaining to dehydration. Although dehydration could be validated through the level of sodium, chloride, and potassium. That's why these electrolytes are being controlled also by the kidneys, because the fluid balance and regulation are merely identified with the kidneys. To continue, so we will not anymore focus on the
Thus, we can say something
on the
like
formula.
500 mils of plasma is being cleared of the drug per minute.
So that's why it's very important to know that the kidney clearance is significant on this. The kidney clearance in connection with the concentration of the drug and your hydration status, the fluid balance, because it will facilitate specifically the more the more volume that you have met the recommended allowance per day, the chances that it will regulate kidney clearance effectively. So obviously, on the other hand, the chances that you may have not met, you may not met or you may not meet rather the specific recommended hydration allowance versus the drug that you are taking, then expect it with the discoloration, and that is an observation that is somehow not balanced with the metabolic products of the drug and at the same time with your hydration status. To continue, this will significantly consider the GFR. GFR means glomerulofiltrate rate. If we say glomerulofiltrate rate, this is the one that initiates the clearance. The higher the glomerulofiltrate rate, the higher chances that it will clear or excrete urine. The lower the GFR or glomerulofiltrate rate, the chances that it will have less excretion of urine. So do you understand what GFR means? The GFR is the one responsible for clearance of the kidney. The higher the glomerulofiltrate rate, the higher urine output is expected. The lower the glomerulofiltrate rate, the lower volume of blood will be excreted. Moreover, more urine are retained in the kidney.
Also have a lower clearance. Thus, drug dosing may need to be adjusted as they will not get rid of the drug as quickly as someone with normal kidneys. Now let's look at the concentration in the urine. Different things can happen to drugs as they pass through the nephron. If they are reabsorbed, then the concentration in the urine will decrease and the clearance of that drug will be reduced.
This is now the problem if it will cause the concern with reabsorption. It must not be supposedly reabsorbed, but there are some situations that it may need to reabsorb on situations that it's needed. But moreover, kasi kaya nga, if we say excretion, it's more on clearance. It will go out of the body. So if there will be a decrease in the clearance, it could be more harmful for the kidney. That's why, class, this may happen during the period of overdosage. For those who experience overdosage, chances supposedly it will increase glomerulofiltrate rate. But the more that it increase the glomerulofiltrate rate and somehow may lead to the possibility of decreasing the GFR, this is now the time that your kidney is at risk. Kaya for those who may have overdosage or may have drug intoxication, the one that will be at risk when it comes to damage, number one is kidney, number two is liver. But more the kidneys are usually at risk of the end consequence of the what we call drug intoxication or drug toxic effect. So in this situation, you will see that the clearance itself of the drug, we have mentioned a while ago, di ba, that the immediately it reached the peak concentration level, the more immediately will release out of the body. The less space of the peak concentration level, the slow it will be removed out of the body. That's why usually most that it reach probably the peak concentration level are for the IV. Pero di ba it may not pass through the liver naman. But it may carried by the plasma. But for inhalation, it may be exhaled by out of the body as a form of the what we call excretion. So to continue, when we talk about excretion, this refers to the elimination of drug from circulation. And what are the major excretion routes? The major excretion routes are, obviously, the number one is kidney. Number two is liver via the bile. Okay? Bile is secreted by the liver. So if the bile hepatobiliary port, if the drug will have its excretion via the hepatobiliary, then it will be appearing via the feces or stool. So those that we have mentioned are rifampicin and the iron-based drugs. Now, lungs as being exhaled, and last major excretion could be breast milk. That's why not all drugs are being recommended for nursing mothers, because eventually breast milk is one of the major excretion routes of these drugs. The minor excretion routes of the drugs could be saliva, could be tears, and could be sweat. So now, when we talk about factors that determine the proper dosing schedules, so we have studied about route of administration. If you can still remember, the route of administration could be enteral or parenteral. So if we consider the enteral, these are the ones that are basically absorbed via the gastrointestinal tract. Parenteral is outside the gastrointestinal tract. The route of administration is merely affected. So route of administration, we're referring to the area of the body where drug absorption will take place. So it could be under the tongue, it could be sublingual, between the gums and the cheek, it could be buccal, oral, going to the stomach. That's the oral route. So via the blood vessel itself or the vein itself is intravenous. So in this situation, the bioavailability change when route change also. So as what I have told you, the more that it complete the process immediately, the one that reaches immediately the peak concentration level, which is the intravenous and the intraosseous, are the ones reaching 100% bioavailability, because this is the one that immediately reaches the plasma. Okay, what is onset of action? The onset of action is the time interval by which the drug is administered until therapeutic effect begins. So what do you mean by therapeutic effect begins? So if we say before the therapeutic begins, before it will reach the target organ. So an example goes, we have ambroxol. So the ambroxol is identified as a respiratory drug. So the target organ or the target pathway of this drug is mainly the mucus secretion on the upper respiratory tract. So when the drug is administered, or if the drug is administered to the patient via oral, so at the start, okay, from the start that the drug had been administered to the patient, it goes to the stomach, goes to the intestine, then detoxified through the liver, reaches the plasma. Okay, once it reaches the plasma, it will be distributed to the compartments. Once it's distributed to the compartments, follow through with the synovial, with the various fluids, specifically for the lungs is the pleural fluid. Then before it reached to its target area in the respiratory tract, that's onset of action. The term onset means at the start, beginning. That's the key term, beginning, onset of action. If we say action, the therapeutic action is it already reached to the level of the completeness of the effect of the drug, because from the time that it is administered to the patient until it reached the desired effect. So that is the therapeutic and desired effect. But if we take into consideration onset of action before the therapeutic effect begins. So the key term for onset of action is begin. For route of administration, the key terms here that you may remember is area of the body. And the bioavailability is the term that is associated with 100%. Now, when we talk about peak concentration level, for peak concentration level, the key term that you may consider here is the maximum, okay, maximum blood concentration. So we have explained here that the route of administration that could nearly reach immediately the plasma may reach immediately the peak concentration level. So maximum blood concentration level. So if we talk about duration of action rather, so let us now differentiate onset of action and duration of action. The duration of action has a more complete process because from the start the drug had been administered and now it already acts on what is its indication. Example, we have mentioned ambroxol as mucolytic. When the drug is already processing of liquefying the mucus secretion to prevent obstruction of the airway passages, that is already duration of action. But if we are talking about onset of action, we are talking about begin, before the therapeutic effect. But once it reach already therapeutic effect that it's in on the process or produces its process itself, that is duration of action. So, any questions so far? Students, you are silent. I don't know if you understand what I'm saying or do you have any questions so far? Are you still with me? Yeah. So I need your answer because I need to assess if I'm still connected with the platform. So do you have any questions? So I only heard Miss Julia to answer about for the others so far. So it, oh, okay. Yan, yung iba galit na. Wala po. So okay. So it means it's clear? Clear po ba? Clear po ba?
Yes po.
Okay,
Yes po,
because
Doc.
later we'll have the assessment exercises. So let us now continue. When we say bioavailability, yan. So when we say bioavailability, we're talking about the drug already reaches 100%. So this is the one I've told you. When the drug reaches the peak concentration level, it's 100%. Okay, peak concentration, maximum blood level concentration, because our target is the drug will reach the plasma, then that's 100%. But once, di ba, the drug reaches 100%, that is not the time that it will process the distribution, metabolism, elimination. The component of the drug will have its effect. Half of it will take into the distribution, half of it will be excreted out of the body as part of the metabolism. So that's what we call naman drug's half-life, wherein the time required for the drug plasma concentration to decrease by 50%. So one of the examples that I emphasized to you before, if the drug is given every 8 hours, so the half-life of the half, what you call this, the peak concentration level of the drug is almost 4 o'clock. So that 4 o'clock time of reaching the 100%, it means that the drug is already taking its effect after that 4 o'clock, which is What is the time between 4 o'clock and 8 o'clock that we consider the half of 4 o'clock and 8 o'clock? What is the time? Half between 4 o'clock and 8 o'clock.
6 po.
Okay, so the 6 o'clock, it means that's the time that the drug is already reaching half-life. So that's already meaning that the drug must reach again 100% by giving it at 8 o'clock. Okay, that's why when you will not administer the drug at 8 o'clock, it will affect the bioavailability. Just the same as when the antibiotics are not completed within the 7 days that has been prescribed, it will not meet its objective of antibacterial or prevention of or inhibition of the multiplication of the microorganism. Next slide. So let us now proceed with self-assessment exercise. After the self-assessment exercise, we'll have a health break. So let's have the first question. The nurse administers the drug intravenously, which is expected 100% absorption, bioavailability, the half-life, duration of action, or the onset. So Miss Jana Mesa first raised her hand. Answer.
Letter A po,
Okay. Availability. So let's see if the answer is correct. Okay, the answer is correct. Bioavailability, because this is referring to 100%. The half-life is referring to 50% on the plasma concentration. Duration of action is when it reached the therapeutic effect, and the onset is beginning or before its therapeutic effect. Let us now proceed to the next question. The nurse administered the drug on the right time and frequency since the drug plasma concentration reaches 50%. We have half-life, we have bioavailability, we have duration of action, and we have the onset. So I think Miss Katrina Prestosa raised her hand first. Answer.
Letter A po.
So the answer is half-life. Let us see if your answer is correct. Correct. Half-life. Because we have mentioned about bioavailability as 100%. Let us now proceed to the next question. The next question is referring to the nurse is aware that the manifestation has been observed at the maximum blood concentration. Choices are onset. Letter B, we have peak concentration level. Letter C, we have route of administration. And letter D, we have half-life. I think Miss Meryl Daniel Manguera raised her hand initially.
Letter B po, peak concentration level.
So let us check if it is the peak concentration level. The answer is correct. So again, when we consider the onset, this is at the beginning prior to therapeutic effect. Route of administration is merely referring to the areas of the body, and the half-life is referring to 50%. Next question. The nurse considers the time interval when the drug is administered until therapeutic effect begins. We have bioavailability. Number 2, peak concentration level. Letter C, onset of action. And letter D, first pass effect. The first one who raised her hand is Miss Julia Tambot. Answer.
C po, onset of action.
Onset of action, because the onset itself is beginning. Let us see if your answer is correct. The answer is onset of action, because first pass effect is referring to the metabolic response or metabolism by the liver, and this is usually applicable to the orally administered drug. So we have discussed also peak concentration level as the maximum level of concentration in the plasma, and bioavailability is the 100%. Next, okay, so I think that ended up the self-assessment exercises. Now we will proceed to the administration of medication. For the administration of medication, again, in the United States, by the setup, they're only considering 5 hours of medication. So this is Trump. Okay, so we're considering right time, right route, right amount, right medication, and right patient. So primarily, this is very important because there are some researches that revealed on the medical administration errors. The medical administration error shows that almost 60% are and 60% or 34 mainly in the form of wrong time, wrong rate, and wrong dose. So very basic, very basic. But highest priority when it comes to safety here is the right patient. Okay? So usually when we talk about the right dose, the most common formula that we are talking about with the right dose is dose D over S times Q. So what do we meant by D? D over S times Q, the most common formula for drug computation. D stands for the dose multiplied by the stock of the drug divided by the D over stock times, I'm sorry, D over stock is dose divided by stock. Dose divided by stock multiply to quantity. So this is the common formula for the computation of the dose. D over S times Q. So dose divided by stock times the quantity. Any question from Miss Mendoza? Miss Anne? Do you have any question? Yep.
Sir, wala po. Kanina po yan.
Okay, sige. So, in this situation, the right patient is very important because although this is my question unto you, how will you identify effectively the right patient? Is it letter A, checking the chart? Letter B, checking the bed tag? Letter D, checking the patient's tag? And letter D, by asking the patient. Which of the four ways can you identify efficiently and effectively on reliability of the patient's identity? Answer. Anyone? Yes, Miss
Pass.
Higuera.
Yung letter C po, yung check yung tag ng patient.
Checking the tag of patient. Any other answer? Any other? Miss Prestosa?
Tatanungin po para po mas ma-verify po kung tama po yung sa pangalan po.
Okay. Actually, those that I have enumerated are correct. It is just somehow setting priority of what could be more effective. All of those are correct, ha? So one of which is mainly to ask the patient because you are also assessing the orientation and alertness of the patient herself. The second could be the patient's tag. Okay? The patient's tag kasi the most reliable person whom you can ask about her identity is by herself, by saying or stating her name. The second could be the second could be the ID tag of the patient because there could be instances why it's not the highest priority. How about if the health personnel misplace or rather have not put the right ID tag to the patient. So that could be chances of error. So third naman is we have the bed tag. So the bed tag could be, but there could be instances that if the patient had been transferred to other beds, so this could mean not reliable, least reliable. And if you will just only check it through the chart, this may not physically identify the patient as the right patient. So how about if the patient is unconscious? How about if the patient is unconscious? So meaning the patient cannot verbalize her name. What could be the other means of checking it? So the other means of checking it is obviously via the bed tag. If the patient is with a significant relative, then the significant relative is the one whom you will ask. But if there are no accompanying relative, the next thing that you may check is the ID tag of the patient. So that is merely the difference of using the ID tag and checking the patient's asking the patient's name as when it comes to reliability. But all of your answers are correct. It so happened when it comes to the level of reliability, it is more on the perspective of asking the patient's name. So here in the Philippines, we have actually nga 10 rights of medications, but there are some references that focus on this 12 nga 12. So D, we have the right documentation. So how will you document do you need to do documentation? The documentation has the legal imperatives. Second, it will protect you. Third, it will validate the nurse's responsibilities. To what extent? Uh, if you are doing the narrative charting, it will identify there the condition of the client before giving the drug. You can identify there if there are recorded adverse reactions of the drug, and it could be identified in your narrative charting as part of the documentation if there are supportive measures that you have done even side effects are observed. Okay, another documentation that you may do is by using the medication sheet. In the medication sheet, you will affix your signature. You must be the one who will affix your signature if you are the one who have administered the drug. Okay? There are some situations like this. Uh, two staff nurses are on duty in the ward, and you have assigned the other nurse to be a medication nurse. And the one that are assigned to you, the other nurse is the one who administered the drug. So which of the two will basically sign the medication sheet? Is the one that is assigned to the patient or the one who administered the drug? Answer. Who is the one who will affix the signature in the medication sheet? The one who is assigned to the patient or the one who have administered the drug?
The one who administered the drug.
Correct. Even though the patient is assigned to that nurse, the one who administered the drug is the other nurse. The other nurse is the one who must sign the medication sheet. Why she is the one who need to sign? Because she is accountable when it comes to anything that happens to the patient. Because if ever physically the assigned nurse is not the one who administered the drug and something happens to the patient, although it is primarily her accountability, but it will be validated for the one who administered the drug. So take into consideration because here in the Philippines, we have the mentality of pakikisama. That's why when we have the trusting relationship among our staff, we must take also the take into consideration also the accountability. Who is accountable of actions? And that accountability is the one who performed the task. Okay, next, the right evaluation is referring to if the patient do not have any adverse reactions, if the patient is improving upon giving the medication for how many days. So those are the things that you may consider also a documentation. And we have A, assessment. The proper assessment is very important. The right assessment is very important because prior to the administration of drugs, there could be withholding of the drug on administration. Why? Because vital signs are very important prior to the administration of drug. One of the examples that I mentioned to you are the drugs that are olol, diba? Yung beta blockers. And beta blockers are the one, its action it slows the heart rate. If the pulse rate and the cardiac rate is lower or deviated than normal, then the nurse must decide, or the nurse has the right to decide with her independent function to withhold the drug because it may take risks on the condition of the client to have sudden drop of the cardiac rate and possibly may lead to cardiac arrest. So that's one. Another consideration is that of upon your assessment, the client is experiencing constipation. So di ba we have mentioned also that when you give a drug, you need also to take into consideration the side effect. If the condition of the patient is constipated, then the side effect that you are aware is it may cause constipation. Will you still administer the drug? Yes or no?
No po.
No, because it may aggravate, the aggravation of the condition may possibly happen to the patient. And you're not protecting the patient, you are not promoting safety to the patient, and you are not applying the therapeutic regimen as prescribed. Next is R, the right reason. The right reason is meaning the right action, mechanism of action of the drug, the right classification of the drug. That's why one of our asynchronous session says that we need to basically know the suffixes, the common suffixes, for us to be familiarized per se. But the mechanism of action is a different story. So if ever you are aware of the classification of the drugs and the mechanism of action of the drugs, you may have high confidence in explaining it and doing health education to your client. Right patient, the right time, okay? The right time, the right time is very important because of the principles. Yan ha, bear this in mind. Why do we need to facilitate right time and right frequency? Because of the concepts of bioavailability and the concepts of half-life of the drug. These two terms are basically the answer when you are about to consider the right time and frequency of administration of drug. Right route of administration, so we have defined this, and we must be aware, class, you must be aware and have the mastery of the 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 time and effect of the drug, which mainly we have identified different rules of administration and its effect of the drug. Because once you will be assigned in the intensive care unit, in the emergency room, this is very fundamental that you must have when you are about to attend to clients in emergency or in critical care units. Right to refuse. I just want to hear from your insight. How about if the client will refuse taking the drug? How will you deal with this?
I-explain po din kung ano po yung magiging side effect kapag hindi po niya kukunin yung medication po.
Okay, that is one. So probably the consequences, if the drug will not be taken. Okay, so probably you can explain. Okay, Mr. Chester. How about if kasi the primarily you will still convince, right? You will still convince the client to take the drug. But how about if the client really insisted to refuse the drug? Yes, Miss Lara.
Sir, informed consent po.
Very good. The informed consent the informed consent will basically apply the principle of autonomy. Okay, di ba sa ano yan? I know you have studied this in your health ethics. Do you have already health ethics?
Yes po.
Yeah. So the principle of autonomy, it's by decision of the client. However, di ba we are bounded with beneficence. Tayo naman as nurses, we are always for the good of the client. However, if the client refused to take the drug, the informed consent has you are practicing the principle of autonomy, and at the same time at the same time you are also protecting yourselves on the legal imperatives. On the matter that the client will refuse to take the drug, always explain the principle of bioavailability and the half-life. If they have already started, the drug, it may not meet its desired effect. Kasi explain nyo, the follow-up explanation that you may have could be the onset and the duration of action. Ma'am, we have already started the drug. You have already received the 2 doses already. The principles of bioavailability and the half-life could be affected because we cut the continuity of the drug. So probably with supposedly target dosage of the drug, it may affect basically the principle po of the onset of action and duration of action. Once you have completed in days the drug po, then the duration of action will be met. But when it comes to the early termination or continuation of the drug, we are probably on the state of onset of action because we are still not reaching the therapeutic effect of the drug. See, you can now already use those principles in giving explanations for convincing the patient when it comes to drugs. Right expiration is very important. I know for a fact that most of you or all of you have encountered, pwede pa yan bukas. Pwede pa yan for 1 month. Hindi pa yan makakasama. So, do you believe in this Do you believe in this somehow mindset? Do you believe in this mindset? Is it correct to have a mindset that you are aware of the right expiration and yet you can still extend time and day and it could not cause harm to the patient? Anyone who can share their insight? Students? Anyone who can share that if you are agreeing to the point na even though the expiration date had been identified, you can still use beyond the expiration date? Is this a correct concept and perception, or this is a misconception?
Misconception po.
So why do you think this could be a misconception?
Kasi po, pwede din pong maka-apekto po yung sa expired na gamot sa patient po eh.
Okay. So actually there could be reasons like number one, it's either the drug may cause harm to the client. The second reason is the drug is not anymore having its potency. The potency that we are talking about is there is no effect anymore to the patient. Even though there are no adverse reaction, even though there are no toxic effect manifestations or signs, but the drug is not anymore taking its effect. So that's why be mindful of identifying if it's already expired, then consider it as expired. Don't even take it. Another way of checking it is if there are drugs that are being diluted through the vials. Change in the color of the drug is a sign, is a manifestation, or is an observation which you must not ignore, because this is one that merely consider that it's already expired and it lose already the potency. Remember, class, it is very important for nurses to know the proper storage of the drug. Some of the drugs are refrigerated, some of the drugs are only stored in room temperature. The next is we have the right education. The right education is very important because just like, for example, we've studied about the side effect. So the side effect itself must be understood by the client so that to prepare them that they're expecting this side effect, but it is part of the action of the drug. So that to avoid misconception and to maintain the what we call trusting relationship among the nurses and the patients. So obviously we have the right drug, so that's why the right drug and the right dose as is considered as part of the first 5 rights of medication, because if you don't have the right drug and the right dose itself, it's either you are considering underdosage of the client or overdosage of the client. So these are naman the 12 rights of medications that we have mentioned a while ago. So before we proceed with the common medication suffixes, we may have first 6 minutes, okay, 6 minutes of health break, and we'll be back at 6:50. So you may have your health break, hydrate yourselves, or probably take anything so that to support your physiologic need. So we will be back. Okay, so let us continue. So we are now proceeding to the common medication suffixes. So this common medication suffixes are very important for us to be aware of the how we will classify the drugs accordingly. These are the most common. As much as possible, classification of drugs are easily identified by the generic over the brand, because the brand name is the brand name from the term itself, brand. These are the names of the drug which had been identified and associated with specific pharmaceutical companies, while the generic name are moreover identified as the functional classification of the drug. So let's start first with the first one. So the first drug are cane. Okay? So what does cane? Any drugs ending in cane are local anesthetics. Sir, there are anesthesias also that are identified as spinal anesthesia, local anesthesia, and general anesthesia. If we say local anesthesia, local is only referring the anesthetic effect is only identified on the specific area of the body. Just like, for example, if the anesthesia had been administered intramuscularly on this area which has a cyst, it will cause only anesthetic effect on that area only. If there are mass that could be removed on the specific area and only the localized anesthesia had been identified on that area, anesthetic effect will only be identified on that localized area. Unlike for spinal anesthesia, the spinal anesthesia is it will cause the anesthetic effect from the waist downward. Okay? If we talk about general anesthesia, the anesthetic effect is throughout the body. So that's why when we talk about the level of consciousness, for local anesthesia, the patient is conscious for and alert. For the spinal anesthesia, since the effect is waist down, so the the abdominal down, so it means that the person is still awake and alert as well. But for the general anesthesia, since the from the term itself general, the anesthetic effect, it may really affect your alertness. So those drugs ending in cane as local anesthesia, from the term itself, local is on the specific area only. Those drugs are lidocaine, bupivacaine, lontocaine. Any drug pa that may come out in the market, such as anmucaine, merylucaine, catrinocaine, even if it ends with cane, that is local anesthetics. Okay? So, next drug. Next suffix or common suffix is referring to done. Okay. Done are opioid analgesics. Plus, if we say analgesics, these are obviously related to pain relief. However, the opioid analgesic, the pain receptor or the pain management is blocked. The pain response is blocked directly to the brain. That's why opioid analgesics are also called as narcotic analgesics. So opioid analgesics, narcotic analgesics, these are the ones that will cause basically drowsiness. So this may have changes. It may cause a pain relief, but it may cause changes in the consciousness of the client. Now, when we talk about those drugs ending in done are the following. We have hydrocodone, oxycodone, methadone. Anything or any drug that ends in done, okay, are considered as opioid analgesics or narcotic analgesics. Now, if you will encounter opioid analgesics or narcotic analgesics, these are drugs that are mainly identified not as over the counter, because somehow these are the drugs that are, since the effect of pain relief is direct to the cerebral system, these are somehow abused drugs. That's why most of the drugs who may most of the doctors who may prescribe, license to prescribe opioid and narcotic analgesics are those with S2 license. The S2 license are retrieved or are identified to any physician, specialized physicians who are authorized to prescribe regulated drugs. If we say regulated drugs, these are drugs that are not prescribed over the counter. So one of the legal control or protection control is the only doctor who can prescribe opioid or narcotic analgesics are doctors who may have S2 license. Next, those drugs ending in mycin. Okay, mycin or MY or MI. Mycin or mycins are antibiotics, antibacterial. The mechanism of action of antibiotics or antibacterial is obviously to inhibit the the multiplication or to inhibit the multiplications of microorganisms, specifically bacteria. We're talking about bacteria. However, there are situations like those drugs ending in mycin are erythromycin, clarithromycin, azithromycin. I know you are familiar with azithromycin because this is the antibiotic nowadays being given for COVID-19. But azithromycin is not a direct treatment for COVID-19. Azithromycin is the one that is given for chances of the possible development of bacterial pneumonia. Kaya yung mga for those who may develop mucus secretions in the upper respiratory tract, kasi dyan di ba yung mismong direct inoculation of the COVID-19 virus and somehow causes also the increased mucus secretions. This may cause the possibility of the aspiration and may lead to possible infection to the patient. So that's why azithromycin are given. So this is a form of antibiotic that can be only given 2 to 3 days only, because these are antibiotics that may significantly have a higher dose effect nito to the patient with possible bacterial infection. So usually erythromycin also are given sa may mga respiratory tract infection. Clarithromycins usually are also given for patients with infection of the stomach, infection of the urine. So somehow one of the nursing responsibilities here po is basically, class, before or prior to taking this drug, the patient must be on full stomach, because erythromycin, clarithromycin, and azithromycin are gastric irritant drugs, even though we have mentioned this in our oral administration route. So since it's already 6:59, so I will cut my discussion on this and we will continue this coming Wednesday, because anytime in 1 minute your quiz will be open. So I will stop my recording as well. Thank you very much.